We'll now go to Dan Clair with treatment of AAAs with short angulated neck, staying on label. Dan? Or outside the lines, one or the other.
Thanks very much, Jim. Now that I have grandkids, I have to talk more about coloring inside the lines than outside the lines. And it's kind of funny because as a surgeon, I think to become a surgeon, you have to paint inside the lines. But to be innovative, I think all of us want to work outside the lines. And that's honestly what I would say is what led me to doing endografts and aggressively doing endografts initially, and I think has led me to be a little more thoughtful about who gets an endograft now and who doesn't. And while my practice at one point was close to 90% endografting, my practice more is now about 60 to 65% of patients getting endografts. I have some conflicts. We all know that standard endografts bring significant benefit for patients, but there are issues. And type 2 endoleaks and distal anatomic issues are one thing, but proximal neck anatomy, without question, is the biggest issue that leads to failure in these patients. Despite this, there's been a rapid evolution in how we treat aneurysms in this country, to the point where there are a number of programs that don't actually even train residents with open aneurysm repair. And some of our trainees are finishing without open aneurysm repair experience. But in this Medicare review that was led by Mark Schermerhorn, you can see that the risk of rupture, which is what we're trying to prevent, is almost 5% in this series of almost 40,000 patients. And the aneurysm-related mortality, reintervention at about 14%, 20%, I need my glasses, in this group of patients. So almost 1 in 5 patients needing some form of reintervention. If we look at hospitalization for aneurysm, even without intervention, there's an increased risk of that in patients who have endovascular surgery. Intervention for complications related to laparotomy or the aneurysm, higher in the group who had EVAR. So, laparotomy issues don't outpace the others. And reintervention or hospitalization for almost any issue after these procedures are increased in patients who have endografting. And in a meta-analysis of the early randomized trials, reintervention rate and rupture rate favored open repair. And for these reasons, patients and people who have long life expectancy, clearly we need to be discussing the benefits of open surgery with and the risks of endovascular therapy. In this look from the Kaiser group with mean 3-year follow-up published earlier in the last decade, what they showed was an increase in the number of patients undergoing EVAR early in the 2000s, but a leveling off and actually decrement of that. And this is partly because of the open interventions, revisions that were required, the ruptures that these patients had, and this is really just at a mean of 3-year follow-up. There clearly were concerns about the benefit that we're providing to these patients. Now, there are a number of studies that claim whether you go outside the IFU or not, there's no difference in outcomes, but almost all of these studies use a significant number of patients with iliac anatomy. And frankly, iliac anatomy rarely falls outside the IFU and is rarely the problem. It's really proximal anatomy. And in this look that Andy Schanzer did with Roy Greenberg before he passed away, of over 10,000 patients, significant sac enlargement in 40% of the patients, and about 40% of these patients were treated outside of the IFU, and that outside the IFU is primarily large neck diameters, conical necks, and highly angulated necks. If we look at late rupture of abdominal aortic aneurysms, it can happen at any time, and the thing that we're trying to prevent is anywhere from 0.75% to about 3%, and this is a relatively short follow-up study. Any non-adherence to instructions for use predicts graft-related events in patients undergoing endo repair. This was over 450 patients, again, just mean of 2-year follow-up, and 48, almost 50% of the patients had one IFU violation. Most of these were diameter of the neck and diameter of the iliac artery. Even in these patients, there were significant graft-related events. In a look at over 100 patients with short neck, there was an inverse relationship between the AAA diameter and the neck length. 40% had lengths outside the IFU, and with that, there was increased need for reintervention and for conversion. When the group using anchors looked at 100 patients with endoleak to identify characteristics, two things that they found were neck diameter above 26 millimeters, which for some of the devices is outside the IFU, but neck length, and we talk about 10 millimeters, but even less than 17 millimeters, increased your risk of requiring some form of intervention and having failure of the endograft over time. Large neck diameter, without question, particularly those over 28 to 30 millimeters, have a dramatically increased risk of problems and a 5-fold increased risk of aneurysm rupture. There are multiple studies that have looked at this over relatively short periods of time. I think this technique should be abandoned in patients. And when we look at angulated necks, there's an increased risk. Again, you're looking at 24 months. This is not long-term follow-up. It increases the need for reintervention, and there's no mortality difference. But again, this is just 2-year follow-up for these patients. If we look at when do problems occur, the longer you follow patients, the more problems you will identify. So with these studies that are at 2 and 3 years, you know that there's going to be more issues that they're going to run into. And there's a direct inverse relationship between the length of the neck and the likelihood of type 1 endoleaks and conversion. And that's been shown in multiple studies and in patients who are felt unfit for open or fenestrated endografting. You can do these things, and they'll work for a year, but they will not provide a long-term solution for these patients. I'm going to skip forward just a little bit because all of these issues related to neck length show the same thing. The shorter the neck, the higher the likelihood of problems. Endo anchors don't really change that. Endo anchors and things that enhance proximal seal can improve sac shrinkage, but it does not resolve this in patients who have unstable or unfavorable neck anatomy. In a recent study that was done looking at going off IFU for rupture, there were 600 patients in the VQI that were assessed for performance of these devices. A third were off IFU, most commonly short and angulated necks. And in those patients who were off IFU, there was increased OR time, blood loss, everything that you would want to avoid in surgery, and increased mortality when compared to open surgery patients. These patients had no benefit or no reduction in their mortality. So when we talk about, even in ruptured situations, compromising, I think it's important to recognize that we may not be doing these patients a favor. This is a study that I think probably is more thoughtful about all of this. And the fact is there are a number of patients who are not good candidates for open surgery, not ideal candidates for fenestrated interventions. And they looked at over 50 studies with reports on challenging necks, significantly increased type 1A and reintervention problems within the first 30 days. Midterm follow-up, again, just a little over 2 years. Type 1A endoleaks in almost 7%, migration in about 2%, and reintervention in 4.4%. And again, when there are multiple unfavorable anatomic features, these devices do particularly poorly. In some studies, each increase in unfavorability increases risk by 25% for patients. In conclusion, EVAR, we know, is a benefit for a number of patients with favorable anatomy, but we need to do something to improve our outcome, and painting outside the lines is clearly not favorable for benefit for these patients. Thank you.